Respected Professor M.L. Swankant sir, Chairperson Emeritus, Professor Achal Gulati sir, the Vice Chancellor MGUMST, the members of the CCR Review Committee, senior faculty members, and dear students. Good morning and welcome to this CCR. I'll just give you a brief information about the department and its working. The Department of Radiation Oncology was established in the year 2015, and the MD program was introduced in the year 2018. Since then, 3 batches have passed so far, and all the pass-outs are working at centers of repute. Since the inception of the department, there is a substantial increase in the workload, and as it is evident from this graph that in the last year only we treated around 1800 new patients, and every day we are treating around 160 to 170 patients, and the machine works since 6 a.m. in the morning till 12 midnight. The most common cancers encountered in the department are the head and neck cancers, the breast cancer, and cervical cancers. These are the faculties available in the department, and in addition to 4 faculties, we have a strong team of the medical physicists. They are 5 in number, and we have around 12 radiotherapy technologists, and they are a strong force behind us to plan and deliver the radiation treatment to the patient. We have an intake of 2 students per year, and soon we will be having more because we have already applied for the enhancement of the seats in the department. These are the equipments available in the department. Just for the convenience of the students, postgraduate students sitting there in the hall, I would like to just give a brief account how these equipments are used. Once the patient is received, most of them are diagnosed and confirmed cases of malignancies. So, and there is a definite indication of radiation therapy in those patients. So the first patient is taken on the CT simulator. This is a CT scanner, but definitely different than the CT scanners available in the Department of Radiodiagnosis for the diagnostic purposes. So with this, we take a CT scan of the patient, which is called a planning CT, because based on this CT, we plan our radiation treatment for the specific patient. After this CT scan is taken, then it is imported to our treatment planning system, which is a highly dedicated, sophisticated software available in the treatment planning room. And with the help of this, we plan the radiation virtually, because radiations are hazardous. We cannot play with the radiation and plan the patient with beam on. So this is a platform where we plan the radiation virtually. Virtually means the target for irradiation is identified, the organs at risk which are critical to avoid the toxicities are identified and located, and the radiation beams are fired on the target, and we decide which set of beams are most suitable for the optimum outcome of the patient. So this is how a plan is done, and once the plan is approved, it is verified, and all the quality assurance tests as per the guidelines are done, and then the plan is finally sent to the equipment, that is linear accelerator, either the true beam or the unique, depending on their indications. Because if the patient has deep-seated tumors, maybe for example in the intrathoracic, intra-abdominal, pelvic region, then we go for the higher energy on the true beam, and if the patient has got lesion in the head and neck region or in the extremities, then we may plan the patient on unique machine. Our latest introduction is going to be the cyber knife. Before coming to the cyber knife, I would just like to give a brief background how this came into being. Yes, sir. Yeah, this is under installation. The machine has arrived, and the first phase of installation is already completed, and the next phase is under completion. So most likely that this instrument will be operational in next 2 to 3 months. So you must have heard different technology with reference to radiation like IMRT, IGRT, SGRT, VMAT. So these are various techniques by which the radiotherapy is delivered to the specific patient as per their indication. But way back in 1950, a renowned neurosurgeon, Lars Luxel, introduced the idea of stereotaxy, and he designed a equipment which was called as gamma knife, because in that machine the source of radiation was cobalt, which emits gamma radiation, and this was the technology was termed as stereotactic radiation or stereotactic radiotherapy or stereotactic surgery, because the delivery of the radiation with the help of this equipment used to ablate the tumor as if it has been removed by surgery. So this was found to be an effective alternative to neurosurgical procedures. So there were many upgradations in the gamma knife. Later on the X knife came, and the latest in the series is the cyber knife. The concept of cyber knife was introduced in the year 1994 by Dr. John Adler, who was also a neurosurgeon. And the present form of the cyber knife, that is the latest version of the currently available cyber knife, that is S7, is going to be installed in our institution very soon. The peculiar feature of cyber knife is that it is a combination of stereotaxy with multiple beams which are fired across the tumor to focus on a target. The stereotaxy ensures the accurate and precise localization of the tumor, and then this tumor is fired by the multiple beams from different directions and different angles, so that they precisely focus on the target, and the radiation is delivered so as to ablate the tumor. Stereotaxy is peculiar in the sense, stereotaxy with the help of cyber knife is peculiar in the sense it has got a peculiar tracking systems, because it has inbuilt tracking systems. It can track the tumors so that it makes sure that the radiation dose is delivered to the predefined target area. If the target area is not identified by the tracking system, the system will not operate. It will give you alarm and the treatment will stop. So this is a very new and precise method of delivering radiotherapy. The stereotaxy is useful for multiple indications, not only in the intracranial tumors, not only for the benign tumors, it can be used for malignant. And this latest, initially the gamma knife, the X knife were used only for the intracranial tumors, but the recent advancement in the field of cyber knife has made it possible to deliver radiotherapy even outside the brain. Any part of the body, if the lesion is small, can be effectively treated with the help of cyber knife. So with this brief introduction, sir, this is based on two components. One is the lightweight linear accelerator, which is planted on a robotic arm. So because of this robotic arm, there is flexibility of movement, and the angulation, so that we can easily reach to the desired anatomical site of the body. X-rays are used. Linear accelerator produces X-rays. Yes, sir. They are 6 MV X-rays. So now I invite Dr. Sanjana to continue.
Thank you so much, sir. Now to proceed with today's CCR, I will be presenting the case of a 58-year-old man with Odynophagia for 2 months. And these are the departments collaborating with us today. The patient initially presented to the Department of Surgical Oncology, and I would like to request Dr. Deepak Samane, third year MCH resident, to kindly share the details of the patient.
On physical examination, patient is conscious, cooperative, well-oriented to time, place, and person. Eastern Cooperative Oncology Group performance status is 1. Patient is fairly weak. No pallor, cyanosis, icterus, clubbing, edema, or lymphadenopathy. On vitals were normal with BMI of 23 kg per meter square. To proceed with oral cavity examination on inspection, no facial deformity, mouth opening, the inter-incisor distance was 4.5 cm. No skin erythema, scar, sinus, or fistula, or no any fullness in naked skin. On intraoral examination, patient is dentulous, 10 tooth. No tooth has sharp edges or loose tooth. Halitosis is present. No trismus, no ankyloglasia or deviation of tongue. A single ulcerative proliferative growth measuring around 1 by 1 cm size present over uvula. Irregular in shape, reddish white in color, with everted margin. On neck examination, neck is normal in contour. Trachea is centrally placed. No visible swelling in neck. Thyroid is normal. No tenderness. No palpable lymphadenopathy. Carotid persistent felt at normal site on both sides. On systemic examination, per abdomen examination is normal. CBS, S1, S2 are normal. No added heart sounds. On CNS examination are within normal. With respiratory examination, we found that there are diminished breath sounds over left supraclavicular area and interscapular area. Otherwise, bilateral ear injuries are present and with vesicular breath sounds. So we proceeded with some hematological workup. In that, complete blood count, renal function test, liver function.
What is your diagnosis now?
From this clinical examination, we presented diagnosis of ulcerative growth over uvula.
That is a finding, that is not a diagnosis.
Sir, it will be of malignant, likelihood of malignant etiology, we having malignant squamous cell carcinoma, probably of uvula, sir.
On clinical examination, you can say squamous cell carcinoma.
No, sir. Malignant.
You should say that.
Yes, sir.
I think it is a malignant growth in the uvula,
yes, sir.
and the most likely histopathology is squamous cell carcinoma. So students make this mistake very often. When a question is asked, you repeat what you have already said. That is not correct. Now a new question is being asked, you have to give a new answer. You may not be able to give this exact diagnosis, but you should say what you are thinking about.
In this situation, the best diagnosis of malignancy of the uvula. So we are looking at this point of time. It has to be confirmed with the pathology, and only then we will come down to this squamous cell carcinoma.
So we proceeded with hematological workup, complete blood count, renal function test, liver function test are within normal limit. Vital markers also negative, and patient PTINR was also within normal limit. So case summary: 50-year male, heavy smoker, with no comorbidities, progressive Odynophagia to solid and liquids over 2 months, having ulcerative proliferative growth at uvula of 1 by 1 cm, with diminished breath sounds over left supraclavicular area and interscapular area, with provisional diagnosis of malignant etiology lesion of uvula. Now I'd like to call Dr. Arzu from Radiology Department to discuss the radiology finding of this patient.
Good morning everyone, I am Dr. Arzu Yadav, second year resident from department. So this is the CECT neck, axial view and sagittal view. Here we can appreciate heterogeneously enhancing mass in the uvula region. No obvious evidence of cervical lymphadenopathy was seen. However, airway is patent, so possibility of malignant etiology could not be ruled out. That's why histopathological examination was suggested. This is the CECT chest, axial view, coronal view and sagittal view. In axial view, we can appreciate heterogeneously enhancing mass lesion with spiculated margins in left hilar region and with its slight extension into the left upper lobe. with abrupt cutoff of superior lobar bronchus. The lesion also seems to be encasing the left pulmonary artery with its ascending and descending branches. Multiple mediastinal and hilar, enlarged mediastinal and hilar lymph nodes are also seen. So, concluding the above described finding from CCT chest, there is a possibility of malignant etiology.
Good morning, teachers, seniors, and my colleagues. Myself, Dr. Varun Vashishta, second year resident of the Department of Respiratory Medicine. The patient came to our department with the complaints of Odynophagia since 2 months and dry cough for 2 months. He had a history of chronic bidi smoking for 20 years, so 20 pack per year was calculated. 1 cigarette pack per year are taken as 43 BDs per day per year. No significant comorbidities was present, no significant family history, ATT intake, or complaints of hemoptysis. And on auscultation, the patient had decreased air entry over the left suprascapular area and the interscapular area of the auscultation. So a bronchoscopic guided biopsy was suggested with an indication of an abrupt cutoff of the left superior lobe bronchus on a CT chest. This is the main carina, the left and the right bronchus. We are going through the left bronchus. Now the left upper lobe, as we can see, has been narrowed and there are infiltrates present on the mucosa. So the left upper lobe bronchus was narrowed, pale and irregular mucosa with cobblestone appearance was seen. And the biopsy was taken from this irregular mucosa with an impression of a query mitotic etiology.
Good morning, respected teachers, seniors, and dear colleagues. Myself, Dr. Shivani Goyal, second year PG resident in the Department of Pathology. So, as we received the 2 biopsies from 2 different sites, first is the uvular biopsy. We received several tissue bits from the uvular lesion that measuring 0.5 into 0.5 centimeter, and that tissue is entirely submitted for the histopathological examination. In the microscopic examination, this is the normal histology of uvula, and this image is taken from the textbook. This is the epithelium, which is the stratified squamous epithelium. This is the epithelium, stratified squamous epithelium, and below that, in the lamina propria, there is a dense.
How many layers of stratified epithelium is there in the esophagus? What is the difference in epithelium of esophagus and stomach?
So in the esophagus, stratified squamous epithelium.
How many layers?
3 layers.
And in the stomach?
You know?
Stomach.
4 layers. GIT.
Squamous होता है या कोई दूसरा epithelium होता है?
So columnar, tall columnar epithelium.
Very simple, but you must know there are 3 layers of the squamous epithelium in the esophagus and in the stomach, the columnar epithelium. And what is the junction known as?
Squamocolumnar junction.
तो सर्विक्स में भी होता है, कैसे होता है? यहाँ पे क्या नाम है उसका?
Transitional zone. J junction.
Yes.
And it would be appropriate for the surgeon residents to know that in the esophagus, the mucosa is the strongest, right? Because the muscles are longitudinal, they don't have the strength. So when you are doing the anastomosis, you have to take the mucosa because the strength is in the mucosa, not in the muscles.
In the submucosa, there is a loose connective tissue and multiple vascular and lymphatic channels. In the microscopic examination of our case, there is a lining epithelium and breach in the basement membrane, and the tumor cells are present in the submucosa, and that arranged in the cluster or nesting pattern. Keratin pulse is also seen, and in the high power view, we can see these cells are round to polygonal in shape with a moderate amount of eosinophilic cytoplasm and large hyperchromatic nuclei. So our final diagnosis is the moderately differentiated squamous cell carcinoma of uvula. Second biopsy we received from the left lung lesion that measuring 0.8 into 0.3 centimeter, and that tissue is entirely submitted. In the microscopic examination, this is the normal histology of bronchus. This is the respiratory epithelium, which is pseudostratified ciliated columnar epithelium, and below that lamina propria, this together called the mucosa. And in the submucosa, there is a pseudomucinous gland. In the microscopic finding of our case, there is a lining epithelium which resembles the same. So this is the pseudostratified epithelium, and below that, in the submucosa, there is a cluster or nesting of the tumor cells. And in a high power view, we can see these tumor cells are large to polygonal in shape with the high NC ratio and mild amount of eosinophilic cytoplasm and large hyperchromatic nuclei. And focal keratinization is also seen. So our final histopathological findings are suggestive of non-small cell lung carcinoma that favors the squamous cell carcinoma. Thank you. Now I would like to call Dr. Sanjana Sharma for further discussion.
Thank you, Dr. Shivani. The patient then presented to our department, and this was the case summary. 58-year-old male, heavy smoker, no comorbidities, with progressive odynophagia to solids and liquids for 2 months. He had an ulceroproliferative growth at uvula, 1 by 1 centimeter. On bronchoscopy, left upper lobe bronchus was narrowed, pale and irregular mucosa with cobblestone appearance seen. CT neck was suggestive of 1.2 into 1 into 0.8 centimeter mass lesion in the uvula. CT chest was suggestive of 4.8 into 5.2 into 5.8 left hilar mass lesion with mediastinal lymphadenopathy. So we arrived at a final diagnosis of synchronous dual malignancies, and namely squamous cell carcinoma of the uvula and squamous cell carcinoma of the left lung. For further investigation, patient was referred for a whole body PET scan, and I would like to request Dr. Gurudas Singh, third year MD resident, to kindly share the details.
Good morning, respected teachers, my respected seniors and my dear colleagues. Myself, Dr. Gurudas Singh, third year MD resident from the Department of Nuclear Medicine. So the patient came to us for 18F FTG whole body PET CT scan. This was the baseline FTG PET CT scan, and as we can see, this is the representative MIP whole body image of the PET CT scan, 18F FTG PET CT scan. And we can see the physiological FTG uptake in the brain, in the myocardium, and the urinary activity. Also, we can say focal FTG uptake and FTG uptake in the mass lesion near the hilar region. So these were the representative axial and coronal sectional images from the head and neck. So we can say FTG avid heterogeneously enhancing soft tissue density lesion was seen in the midline in the oropharynx, which was 5.9 in the SUV and measuring approximately 1.3 into 1.4 centimeters. These were the representative axial sections of the mediastinum and the thorax, which represent heterogeneously enhancing FTG avid soft tissue density mass lesion in the left perihilar region with few FTG avid ipsilateral mediastinal and hilar and the contralateral right upper and lower paratracheal mediastinal lymph nodes with a target lesion having SUV max of 15.4 and measuring size of approximately 4.5 into 4.2 into 6.4 centimeters, and various lymph nodes were also FTG avid and having few of the representative FTG activity and the size of the right lower paratracheal having the FTG avidity of 6.7 and measuring approximately 1.6 into 1.6 centimeter. So the impression was a metabolically active, enhancing soft tissue density mass lesion involving the midline soft palate uvula of the oropharynx, likely primary neoplastic disease, and metabolically active, enhancing large irregular soft tissue density lesion at the left perihilar suprahilar region in the left lung upper lobe, likely primary neoplastic etiology with metabolically active, discrete bilateral mediastinal lymph nodes, likely loco-regional metastasis from the lung region. So I would like to call back upon Dr. Sanjana.
Thank you, Dr. Gurudas. Now the case summary, again to summarize at this point, 58-year-old male, heavy smoker, no comorbidities, progressive odynophagia to solids and liquids, dry cough since 2 months, soft tissue density mass lesion in uvula, and a large irregular soft tissue mass lesion at left perihilar, suprahilar regions in left lung upper lobe, with bilateral mediastinal lymph nodes. So synchronous dual malignancies of uvula and left lung, both squamous cell carcinoma. The uvula was clinically staged as T1 N0 M0 stage 1, and left lung was clinically staged as T3 N3 M0 stage 3C. Now, as Sir mentioned, we also had similar challenges while dealing with this patient, as he was a middle-aged man with a good performance status, and we wanted to offer the best possible cure. So we were initially confused about whether it is a synchronous malignancy or a metastatic, and whether the primary of the uvula has a lung metastasis or primary of lung has metastasized to oropharynx, and whether the small primary of the uvula be subjected to surgery or not. So I would like to raise a question to the audience on how you think we should proceed further in this case.
A very good morning to all the respected teachers, seniors, colleagues and juniors. I'm Dr. Chhavi Goyal, a second year medical oncology team president. So as we discussed, the patient is a 58-year-old male with good performance status and a dual malignancy synchronous with a squamous cell carcinoma of lung with stage 3C and a squamous cell carcinoma of uvula stage 1. So the final plan decided was to go ahead with a neoadjuvant chemotherapy with paclitaxel and carboplatin, 4 cycles every 3 weekly, with a dose of 175 mg per meter square of paclitaxel and carboplatin with a dose of area under curve 5. Followed by a concurrent chemoradiotherapy which involves EBRT to face, neck and lung mass with weekly chemotherapy for 6 cycles. So now, what is neoadjuvant chemotherapy? The use of systemic therapy before definitive local therapy is generally referred to as induction or neoadjuvant therapy. Its advantages are, it helps in the early eradication of micrometastasis, cytoreduction of local disease, improvement in resection rates, and in vivo test of chemosensitivity. So before chemotherapy, preliminary blood tests were done to assess the fitness of the patient to receive chemo. 4 cycles of paclitaxel and carboplatin was given every 21 days. Patients was assessed for chemotherapy-related toxicities and clinical response before, during, and after each cycle. Coming on to concurrent chemotherapy. Concurrent chemoradiation refers to administering chemotherapy during the course of radiation. So 6 cycles of weekly chemotherapy was administered along with radiation course. The advantages of giving concurrent chemotherapy are to enhance the tumor radio response, improving the local regional tumor control, decreasing or eliminating the distant metastasis, and preserving the organ or tissue integrity and function. So the patient was administered chemotherapy along with radiation, again paclitaxel at a dose of 80 mg per meter square and carboplatin with area under curve 2 every week for 6 weeks along with RT. He overall tolerated the treatment well.
Post 4 cycles of neoadjuvant chemotherapy, patient had symptomatic...
बोर्ड ने डिसीजन लिया तो ठीक लिया.
In science, there is always a debate.
No, that's all right.
2 different boards may take 2 different decisions.
No, but here because we are one board and there are side effects of the surgery also. It is easy to say that 7 days or 10 days healing will be there, but then if you start doing chemotherapy, the surgical healing might be delayed, and then it will create problem with the radiation. So the decision is combined, collective, and wise decision is what I know.
No, that is why my introductory statement was for the sake of debate.
So, what she is saying is right. It will be decided by the histopathology. If the margins are close, we'll have to do a resurgery again. If there is a depth of invasion is too high, then we have to give radiotherapy anyway. Right? So, that all those things which have to be decided is on histopathology.
And surgeons, our onco-surgeons were part of the tumor board. We have their signatures on the recommendation.
Post 4 cycles of neoadjuvant chemotherapy, patient had symptomatic relief and he was further advised for a CCT neck and thorax as part of response assessment. On CCT thorax, we could see soft tissue lesion in the left perihilar or hilar region encasing the left lobe bronchus, which measured approximately 16 by 20 mm versus the 4.8 into 5.2, 5.8 centimeter in the previous scan, with subcentrimetric mediastinal lymphadenopathy. It was suggestive of a radiological partial response. CCT neck was suggestive of normal study of the oral cavity and oropharynx versus 1.2 into 1 into 0.8 centimeter lesion with subcentrimetric lymphadenopathy, suggestive of a radiological complete response. Based on the assessment, patient was further planned for radical radiotherapy with concurrent chemotherapy simultaneously to primary uvular site and bilateral neck to a dose of 70 gray 35 fractions, 2 gray per fraction, 5 fractions a week over 7 weeks, and for the upper mediastinum and left upper lobe of lung to a dose of 60 gray 30 fraction, 2 gray per fraction, 5 fractions a week over 6 weeks. Now the first step in radiotherapy planning is the preparation of a cast or mold, as we can see in this patient. And individualized thermoplastic molds are created for each patient, and in this patient we created one for both sides together, for the head and neck and thorax. The purpose of the mold is to ensure immobilization of the patient during treatment so that the radiation beams hit the target at the same point with each fraction. After this, patient is subjected to a CT simulation with contrast for both sides with proper isocenter marking in fiducials, and 3 mm cuts were taken. Post this, we do contouring on the planning CT scan. Now in contouring, first we delineate the gross tumor volume, which is depicted in red, and it accounts for any apparent tumor visible on the CT scan. This is then given a margin of 1 centimeter to account for the clinical target volume of the primary, to account for any microscopic spread of the disease. Similarly, in green, we can see clinical target volume of neck, which stands for the elective irradiation of the neck nodes. And both the CTVs are then given a 0.5 mm margin, which is seen in blue, to account for the planning target volume that helps with setup error and motion of the patient and organs during treatment. Similarly, for lung, first the gross tumor volume was delineated. This was given a margin of 0.6 centimeter according to guidelines for squamous cell carcinoma of the lung. And since mediastinal lymph nodes were present in the scan prior to NSCT, mediastinal has to be electively irradiated, and it was also contoured accounting for clinical target volume of the mediastinum. Both CTVs again given a margin of 0.5 mm for planning target volume. This is the final contour of the patient, displaying the different regions receiving different dose. The primary of the uvula receiving 70 gray 35 fractions, elective nodal irradiation was subjected to low dose, 56 gray 35 fractions. Similarly, elective mediastinal irradiation was low dose, 46 gray 23 fractions, and primary of the lung was subjected to 60 gray 30 fractions. We also contoured the organs at risk, which stands for organs that are near the radiation field, and so that we can assess the exposure of radiation in these organs during treatment. And as we can see, that from the dose achieved, they were all within permissible range for these organs. After this, the contour is given for planning, and if plan is evaluated. To discuss this further, I would like to call upon Dr. Kavita Bhati, Senior Resident, Department of Radiation Oncology.
Good morning, respected teachers and colleagues. I am Dr. Kavita Bhati, Senior Resident, Department of Radiation Oncology. Once the contour is made by clinician, radiotherapy planning is done by the medical physicist. Here we can see that the intensity modulated radiotherapy technique was used and 7 fields have been used. Once the planning is done, plan is evaluated. Here we can see a isodose color wash of 95%. That shows that the target has been adequately covered. There are no areas of overdose or underdose. Before executing the plan, a patient-specific quality assurance is done. That is done to identify if there is any discrepancy between the dose calculated by treatment planning system and that delivered by the machine. Once the QA is passed, patient is made to lie supine on the couch, and the same position is reproduced as that was done during the CT planning. And again, another image is taken, a low-dose CT scan is taken of the patient, and the image is matched with the planning CT. When the difference between the matching is done is less than 5 millimeters, then only the radiotherapy can be executed. Despite all these challenges, we were able to deliver curative dose with concurrent chemotherapy without any treatment delay in a span of 7 weeks. Patient tolerated treatment fairly with grade 1 dermatitis, grade 2 mucositis, grade 2 hematological toxicity, grade 2 esophagitis, and there was weight loss of 3 kg. Patient was daily reviewed for assessment of toxicity, vitals, and oral hygiene during the treatment. His nutrition counseling was done, and the toxicities were managed conservatively. Nasogastric tube was placed for maintenance of nutrition and esophagitis. Local anesthetic syrup was given and GCSF was given subcutaneously for hematologic toxicity. His toxicity grading was done as per CTCAE grading criteria. Patient was then followed up clinically post-treatment. On first month of follow-up, he had grade 1 dermatitis, grade 1 mucositis, grade 1 esophagitis. He had complaint of mild cough. There was no weight gain. Hematological reports were normal. He was able to eat semi-solid diet and nasogastric tube was removed. On second month of follow-up, there was no mucositis, dermatitis or esophagitis. There was no fresh complaint. He gained 1 kg weight. Hematological reports were normal and he was able to eat solid diet. At third month of follow-up, there was no toxicity. He had no fresh complaint. He gained 2 kg weight. Hematological reports were normal and he was able to eat solid diet. At 3 months, as per protocol, the patient was advised for whole body PET CT scan. As compared to the baseline, there was significant response and the SCP also decreased. Post-treatment bronchoscopy showed post-radiotherapy changes and the study was normal. I would like to invite Dr. Sanjana to take over.
To conclude today's CCR, I would like to discuss the lessons learned from this particular case. To begin with, diagnosis was a challenge in itself as we had to differentiate whether it is a metastatic or synchronous malignancy. But fortunately, we have an eminent team of senior oncologists comprising a multidisciplinary tumor board in our hospital, without whose guidance appropriate treatment of this patient would not be possible. Since each patient's characteristics differ and every tumor has its individual anatomy and biology, its location, whether it is near vital organs, and how they would respond to therapy, treatment had to be tailored to fit every individual and each tumor. Side effects in this patient were expected to be greater than others owing to the long radiation treatment field, and the extra care was taken for their assessment and relief. In our department, we have the privilege of adaptive radiotherapy due to availability of image-guided radiotherapy, because of which weekly CBCTs were taken, assessed, and depending on response to treatment as the tumor size decreased, resimulation of patient was done and new contours created to fit the need of the patient in between treatment. Also, the lung is an organ forever in motion and it is difficult to keep the tumor stationary throughout treatment for radiation beams to target, but it is made possible with image-guided radiotherapy, and we will be better able to cope with this problem with the new CyberKnife machine. This is a small literature review about the incidence of synchronous malignancies. And the basic essence is that approximately 5% synchronous primary malignancies were discovered in all these studies, with head and neck being the site with majority of them. Until date, approximately 16% cases have been documented in the SEER database of synchronous malignancies. So take-home messages: any unusual additional site of disease should be thoroughly evaluated to rule out rare possibilities of a second primary. Synchronous dual malignancies are not uncommon. Meticulous workup should be done in all patients. Guided biopsies for suspected cases should be carried out. And a multidisciplinary tumor board assessment and evaluation is mandatory for optimal outcomes. To end, I would like to thank the management of Mahatma Gandhi University for bestowing upon us the latest technologies and their unceasing support in our attempts to provide patients with the best treatment options there are.